Warm welcome to all my dear MOS members and the ophthalmic fraternity who have joined today. Well, we have a very interesting webinar, and the topic is pediatric cataract surgery preferred practice guidelines. With us, we have one of the most renowned PG teachers, Dr. Krishna Prasad from Hubli, that is Joshi Eye Hospital. He has been the most sought after teacher, and we have with us also renowned panelists. We are in-house consultants, Dr. Nikhil Rishikeshi. He is the head of the Department of the Pediatric Ophthalmology in HUDSI Hospital. More about him we'll be telling as we progress. We have Dr. Prasad Walimbe. He is also a pediatric ophthalmologist, and Dr. Zai Kelkar. She is the honorary president of the Pune Ophthalmological Society and a pediatric and a squint surgeon. So we are going to have a very lively session. I had a discussion with Dr. Krishna Prasad. He said we'll have a proper, lively, interactive session to have the points put across to all the target audience. Today, I'm sure we are going to have all the postgraduates who are seeing this, the fellows, and the fresh consultants who have joined. And of course, as you know, the general ophthalmologist always has a view. If you have a pediatric cataract, how to go about it? There is always a dilemma in the mind. So we are going to have a very interesting session with us. I have my secretary, Honorary Secretary, Dr. Rajesh Joshi also. So a warm welcome to all the speakers and the panelists here. So now I hand over the proceedings to our moderator come panelist, Dr. Nikhil Rishikeshi, for the further proceedings. Over to you, Nikhil.
Yes, sir. Yes, a very good evening, everyone. And our very dynamic president of MOS, Dr. Daswal, has already said, a warm welcome to all. I don't know how many activities, Dr. Daswal, you are doing. What people do in 10 years, you're doing in months. Hats off to you. And all of them are very relevant. So pediatric cataract, as we all know, is a little bit of a gray zone because there are a few things that are not done the way that cataracts are done in the adults. And we do have a very esteemed faculty invitee with us, Dr. Krishna Prasad, sir. Warm welcome to you, sir. And a very brief introduction about Dr. Krishna Prasad is he is obviously the head of pediatric ophthalmology at Joshi Eye Hospital, Hubli, and at least 23 to 24 years experience in PG teaching and fellowships in pediatric ophthalmology. I think his fellowship is also very sought after fellowship, and a lot of surgical work is being done at Joshi. I recently learned that Dr. KP, or I'll refer to you as Dr. KP if that's okay. Yeah, with due respect, sir. So I learned that they're doing 8-10 pediatric surgeries on a daily basis or whenever he's operating, and that I think itself speaks volumes about the work that is being done in the community, because that is where the need lies. I mean, there are so many kids that need so much assistance and evaluation and great surgery. So thank you, sir, for doing your bit to cover up that part of the community. And he has done his fellowship at Storm Eye Institute, which is a very famous destination in South Carolina, USA. So all of us have heard about Storm Eye Institute, and it offers a very good pediatric ophthalmology training program. So that's where Dr. KP has trained. He has 3 international and 8 national publications in peer-reviewed journals, more than 23 years of experience in PG teaching and fellowship training programs, more than 200 presentations all over national and international at international venues. So it's wonderful having you here, sir. And we look forward to a very interactive session. Dr. Prasad Walimbe, of course, our homegrown boy, we can call him, but he actually grew up in Arvind Eye Hospital, Madurai, and he trained under a very, very favorite of all of us, who's Dr. P. Vijayalakshmi Madam, who's the pioneer of pediatric ophthalmology in our entire country. So Dr. Walimbe, hats off to you. And he is the pioneer of pediatric ophthalmology in Pune, I would say. He's the senior most, at least 24 to 25 years of experience. And he's doing, even though he's a private practitioner, he's doing a lot of community ophthalmology and community pediatric ophthalmology. He has authored a beautiful book called Step by Step in Strabismus Surgery, which the proceeds of the book, whatever this thing is there, the proceedings or the money, it goes to poor children for their spectacles fund. Say, I learned about that just today, sir, and that's a very novel way of helping out the children in the community. So thank you so much for that. And lovely work that is being done by Dr. Vanembe is always an inspiration to us. And our third panelist, of course, is Dr. Zai Kirkar, who is our president of the Pune Ophthalmic Society for this year, FRCS and FRC off from Glasgow and Edinburgh both. And she also has more than 40 presentations, or 40 publications rather, and innumerable presentations all over. And Dr. Zai is also the pediatric ophthalmologist and squint surgeon and medical director of NIO Pune, National Institute of Ophthalmology. A very active surgeon, a very excellent clinician, and a very, very avid fitness freak. So every time we look at her, she gives us a huge complex because she's fitter than the last time. So I don't know how that can happen. You keep getting fitter and fitter. But so we have a lovely sort of get together and gathering of pediatric ophthalmology lovers. Without further ado, I would like to call upon Dr. KP to unmute himself and please start with the session. You're welcome, sir.
Thank you. Thank you, MOS. Thank you, Dr. Taswala. Thank you, Nikhil and Prasad for being my trustworthy lieutenants in this odious task. It's very heartwarming again to be in the MOS webinar. It's one of the most sought after, well attended, and one of the finest deliberations on science, and very well disturbed by the president himself, Dr. Taswala, who's taken so much keen interest in trying to disseminate the information, and he moderates it so well. So without much ado, we'll just start the session. And the small difference here is that we have 4 postgraduates who are actually. Can you see the screen?
Yes.
Yeah.
Okay. So again, as the practice goes, it's a preferred practice guidelines. We're not really talking too much of complicated intricacies in the management of anything. Basically, we just look into what is to be done and why. And this is for basically, we are aiming at the comprehensive ophthalmologists and the postgraduates in general, and not for the so-called pediatric ophthalmologists. So we'll be basically oversimplifying certain things and not well into the too much of controversial areas. We'll just go into it, and we have to represent, welcome Dr. Jai also. So yeah, he will also be really helping me out in trying to get this across. We have 4 postgraduate students, and I believe they're already there on board.
Yes.
They can unmute themselves whenever they're asked a question. Anybody can unmute and just put it across, because whatever is their answer or their query will basically we take it as the query that we need to solve. So that's the whole idea of having them here, so that we have an interactive session. So why it is important? I mean, why this pediatric cataract management is so important? See, as Dr. Rishikeshi actually alluded, there are a lot of surgeons who do an excellent cataract surgery in adults. So when they can do it in hard nucleus, when they can probably do it in more difficult situations, pediatric cataract is a very soft cataract, hardly any nucleus. You can just suck it out even without using any phacopar. You can just aspirate it. You can do a phaco aspiration. So when that is so easy to do a cataract surgery, why all this noise about pediatric cataract management? So this is something that we need to actually decide or discuss today. It is not about the actual technique. The technique is slightly different from as of adults. At the same time, what is more important is the evaluation itself. Even detection of cataract is so important, and to decide should it be operated or not, because not all lens opacities in children need the removal of cataract, and the surgery itself may not be very important thing. It may not be very complicated part of the whole chain, but what happens and what unleashes after the cataract surgery is probably very, very important. That decides, that makes or breaks the whole situation. So the post-op management, looking for complications and taking the growth of the eye along and trying to give the best optimum visual recovery in the given situation is a very difficult ordeal for all of us together, especially the pediatric ophthalmologists. I think the management lies on everybody in this ophthalmology, and also with the assistance from the pediatricians and sometimes physiotherapists and so on. So the very important thing, why cataract surgery, or and when to do it, and which surgery, and which IOL and things like that, and how to do it. These are some of the questions that we will be answering in the most simplistic manner. So why cataract surgery? Probably very importantly, if you don't operate a pediatric cataract, unlike an adult, the child develops amblyopia and it will be having a subnormal vision for life. This is where the whole difference comes. This is where the urgency comes. This is where the importance of doing an early surgery comes, and doing it right comes. So in an adult, we can always wait. Nothing will happen. The surgical outcome or the visual recovery will be same regardless of when you operate. Okay. But in a child, it makes all the difference. So this is very important. So that's why we need to not just educate our own fellow ophthalmologists and postgraduates. We need to educate our fellow colleagues in pediatrics, obstetricians, who will be seeing the child at a much younger age group, and before, whether they refer or not, whether they can detect it. So pediatricians, when they see the child immediately after birth, can they detect it? And when they go for the subsequent visits to pediatrics for vaccinations, can they detect it? See, all these becomes a very important gamut, and this is a combined responsibility of everyone to, just like ROP, even pediatric cataract, we need help from our pediatrician friends. So when to do it? So this is something very important. If it's a unilateral cataract, you find a child having a cataract only in one eye, and let's say you see it very early in life. Should it be operated on the day 1, day 2, day 5, day 10? So there is urgency, of course. At the same time, the child is just born, a lot of things are getting set, and the child has to undergo a major ophthalmic surgery under general anesthesia. So that makes all the difference, that it need not be, it has to be as soon as possible. I mean that we can always wait for 4 to 6 weeks till the systemic consolidation happen, till the pediatrician or the pediatric anesthesiologist are ready to give anesthesia. Obviously, it is not a very deep anesthesia, it is not a very prolonged anesthesia like as in other surgeries on the abdomen or elsewhere. It's a short anesthesia, but even then, a child really requires a proper workup and a fitness, which is good enough, because life is more important. So we need to wait for it. So there's no hurry to do within days. It is done in weeks, 4 to 6 weeks, maybe an end of 1 month or 6 weeks, looking at the child's fitness. If the child is born with some birth problems, born with prematurity, born with low birth weight, has gone through some eventful immediate postnatal period, so it is prudent to wait till the GA fitness is obtained from the pediatrician. So this is something very important. The postgraduate should know that it is not immediately after birth. If you find a cataract, don't post the patient on day 2, day 3. It is not the right thing to do. But it's a bilateral, it's slightly a different game. This is the difference between a bilateral and a unilateral cataract, because once the child starts seeing, the visual the development starts soon after birth. Okay, most PD should know that the child is not seeing at birth, even though the relatives may claim it that way. The child starts seeing slowly in few days to week. It starts a very gross sense of vision. The fixation itself starts around 4 to 6 weeks to establish. So the visual recovery happens over days and weeks. It starts, the visual development, the entire visual pathway, okay, from the retina to the occipital cortex starts. But if it's a bilateral thing, the visual signals are not reaching the cortex in both the eyes. So there is no rivalry. So that gives a leeway or a little extra time for us to actually wait. In a unilateral cataract, one eye is basically taken away from the participation. The other eye is actually already started developing the vision. So there is a rivalry. There is an abnormal binocular interaction along with the deprivation of form vision in the eye which has a cataract. So there is an element of increased chances of amblyopia or a more profound amblyopia if you delay a unilateral cataract. That element of rivalry is not there in the bilateral cataract. So you can probably wait a little longer. It doesn't mean that you need to wait longer in the bilateral cataract. But if the situation demands, probably it is prudent to wait, okay, in a bilateral cataract rather than a unilateral cataract. That is the whole idea. So there's a small difference in the time that you operate. And what about the second eye? A lot of people do a bilateral, a simultaneous, or what we call a sequential cataract surgery. Like you operate one eye and you operate the other. Okay, in the same setting, of course, with all the due precautions. But there are some people who operate one eye and follow it after a few days. Again, there is a new evidence that has come in from the Department of Anesthesia, pediatric anesthesiology, where they do, discourage immediate, general anesthesia exposure within few days, because it's a developing brain. So there is some insult to the developing central nervous system when you put a child under deep GA. So that has some, time for it to kind of go out of the system. You do a surgery today and soon after 2 days, you do another eye. So that has a compounding effect. So they do wait for a washout period of maybe around 10 to 14 days. So between the two eyes, normally at 2 weeks in a very small child, like I'm talking about few weeks to few months, an infant, in a very young infant. So this difference is also sometimes important, keeping the effect of general anesthesia on the child's developing central nervous system. So that is something very, very important. Dr. Nikhil, what is your take on a bilateral cataract? Would you give a gap between the two, or would you also think of a immediate sequential surgery?
So my preference would actually, the anesthesiologists are the one who are going to take that call for us, isn't it? So
Yes.
if they say that it is not safe to give an immediate anesthesia in 4 days or 5 days or 8 days, then I would rather operate both eyes together, because I think we don't want the operated eye to become the dominant eye and the unoperated eye to go further into suppression, which is already both of them are suffering. You operate one and do partiality to the other, unknowingly or unwittingly and unwantedly. So I think the anesthesiologist, if he's ready for a repeat surgery in a week, less than a week, 10 days, then it is all right. But most of the times, I am doing simultaneous surgery on both eyes, at least up to the age of 3 months.
Okay. So I think this is very important. I can't agree more, because here there is no element of this IOL controversy, because we are not putting any IOL. So just a removal of the cataractus lens. So you can always combine that, both the surgeries in the same sitting with the due precautions.
Yes.
Obviously, you need to change the set. You need to take all the precautions. Okay, there are two different surgeries just done sequential.
Correct.
Normally, the people were using the word simultaneous. Now I think we have replaced it with sequential. Immediate bilateral sequential cataract surgery. That is the new buzzword in adult cataract surgery also. What about you, Dr. Valimbe?
Yeah, I agree with Nikhil as well as you. With the current evidence, at least till 1 year of age, I always do bilateral surgery in one setting. And as you correctly pointed it out, it should be treated as a different surgery. You change the everything, including the set, including your gown and everything, and you treat it as a second surgery. But because of the anesthetic problems, so even though anesthetist is ready to give anesthesia within a week, I would prefer to do a bilateral surgery in one go, because even the gap of 1 week also quite amblyogenic at this age.
Yes. And because if you do it too quickly, the anesthesiologists say that there is a cumulative effect of anesthetic drugs, especially within the first 3 months. That is what. So it is something very important.
But for the secondary IOL, I always wait.
Yeah, that's fine. But for the removal of cataract itself, so immediate sequential surgery is one option, because the anesthesiologists say that whether you give a 10 minutes GA or a half an hour GA, so there is not much of a difference in the risk.
I agree.
It is an all or none thing. It is not actually time dependent. So basically, they say once you put a child under GA, there is always a seminar. So you can probably reduce the risk of 2 exposures and take away all the logistics. Also, will be probably better. Okay, so
absolutely.
So that answers well. But which one to operate? A lot of different types of cataract. You have a small, big, covering the entire lens, sometimes in some part of the eye. So you have all types of different morphologies. So which one to operate? Not all lens opacities in a child need cataract surgery. So this is a very important decision to make, because what happens is, if you remove the cataract in a lens in an eye where, it is not probably visually not significant, what are you losing? You may probably improve the vision for the child for distance, but you're knocking off a very important gift of nature, that is the accommodation, which is so important in a young child. A child's world is basically close to it. So it's a very small world. Okay, the child doesn't see beyond, a small distance. So basically the near vision is something which is important for the child's developing, all the information, the sensory input to the developing brain comes mainly from the eyes, the vision. So if you knock off the accommodation by removing the lens for reasons of improving the distant vision, you're depriving a child. So it's a very intricate and a very difficult, a balancing act. You need to understand, are you harming by removing the cataract, or are you gaining by removing the cataract? So there are many situations where, for the sake of accommodation in near vision, we sometimes, forego a better distant vision for that child till a particular time. So, so it's a visually significant. This is a very important term. Visually significant. If any cataract is more than 3 millimeters in terms of its size, like usually you have zonular cataracts and lamellar cataracts, which are very small, like 1-2 millimeters. Normally the child's eye the pupils are slightly dilated. So in a normal scotopic pupil or in a mesopic pupil, okay, usually you have enough clear area around the opacity so that the child can see well. Okay, so anything which is more than 3 millimeters is likely to obstruct the quality and the quantity of vision. So this is an important parameter. If you're doing an examination anesthesia or in a slit lamp examination, the child allows, this is one of the parameters. The size is something very important. The density of cataract. Okay, is it really blocking the light? And so most of the posterior polar or the posterior subcapsular cataracts in a child, so because it is close to the, the nodal point, they cause more visual disturbance to a developing eye. So that is something that should be taken more rather than anterior cortical or peripheral cataracts. And if they have in an undilated state, in a semi-lit room, if you see a distant direct ophthalmoscopy and if you have an obscuration of the globe, I think this is very important. A child will not probably allow a slit lamp examination, but a distant direct ophthalmoscopy is so important because that really says how much is the light being blocked. Because you may, in a torchlight, you may see an opacity, but it may be actually translucent. You may have a good glow with that cataract. So that is not the issue. The point is the distant direct ophthalmoscopy, like any cataract, even an adult, this is the most important message that we give. So you just do a distant direct ophthalmoscopy and to see how much the glow gets obstructed. If the child already has a nystagmus or strabismus, okay, which is already meaning that the child is not participating in the vision, the visual axis has gone astray, which is a direct indication that the child's vision has to be restored. Otherwise, it will go for a much deeper sensory adaptations. And if the child is near vision, it's in a bigger child, if you think that the child's near vision or reading vision is reduced, that means it's a very significant cataract. Okay, so you basically go by various parameters. There are some dicey situations or gray zones where you cannot really come to a conclusion. If you are in doubt, rather wait than to knock off the lens because it's a one-way street. So you better wait. You allow the child, maybe you can dilate the pupils with homatropine. If you think that there is some kind of a borderline situation, there is dilatation of pupil with the homatropine at night can be an option to probably tide over the crisis to buy time. Okay, rather than going ahead with cataract surgery. So you should never be aggressive in a pediatric cataract because once you remove the cataract, the whole thing, basically you're upsetting many things and getting the child on the track would be very difficult. So basically now this is the time for the postgraduates to chip in. Okay, what causes pediatric cataract? Okay, before that I would like to just ask, you have Dr. Kiran and you have Dr. Sally. Dr. Sally, what is the easiest way to prevent a pediatric cataract? The easiest prophylaxis that you can think of in general? Can you tell me? Like if you want to prevent, you're given a project to prevent or to reduce the incidence of pediatric cataracts, okay, childhood cataracts, what one simple thing you would advocate to the community?
You
okay,
turn on the video also.
Well, you can unmute and talk.
Yes, sir. Parents counseling and identification of a white reflex in a pediatric patient.
No, I'm not saying detection. I'm saying prevention, primordial prevention. Like in a community, you want to reduce the burden of pediatric cataracts. What will you tell the health agencies to do? Dr. Kiran? It's like an exam. No, I have something in mind. You have something else in your mind. Easiest thing, I said. Health agencies.
So,
What can be done in the
hereditary
community?
and congenital causes are more common. So, proper genetic counseling can be done.
The genetic counseling by an health agency, is it different? You see, for everyone. So it can't be universal health genetic counseling, no?
Any intervention?
Any vaccination.
Vaccinations.
Any vaccination.
Rubella.
Yes, so that was I'm aiming at. So this is what. So if you probably make sure that all the girls, okay, I mean of a particular age group are taken care with rubella vaccination, you can. It's not just the cataract. They also have other congenital problems like heart conditions and things like that, deafness. So you can reduce a great amount of pediatric morbidity if you institute rubella vaccination as a compulsion. I think this is something that we still, it's an unsolved problem. I think we still have a lot of, so that was the right answer. Yeah. So we just divide this is for the postgraduates and for basically the general consumption. So what really causes, I just quickly go through it. We take it as unilateral and bilateral cataract. So bilateral cataract, the most common cause is idiopathic. We really do not know why it happens. Okay, almost nearly half the cataracts that we encounter, bilateral cataracts, we don't find a cause. So we put it as idiopathic. There may be a cause, but mostly we don't find it. And the next most common is hereditary causes. That means there is some amount of familial tendency. There is some amount of genetic transmission. And there are all types are possible in a cataract. You have an autosomal dominant variety where you find all the children in that family having cataract. No, I think Dr. Nikhil and Dr. Prasad must have seen like a family of 2, 3, 4 kids, having cataracts in both eyes. So they are the autosomal and dominant variety. You also have autosomal recessive. Only one child gets affected and none others. It doesn't happen. And you will also have an X-linked. So all types of transmissions are possible in a hereditary type of cataract. And the next important is metabolic and genetic diseases. I think this is very important for you to understand. It is not only for the exam. Even if you get a child in the OPD with a bilateral cataract, you should start thinking in these lines. So metabolic and genetic diseases. So like you have galactosemia, you have homocystinuria, okay, or you have hypoglycemia. Basically, it is a hypoglycemia in the immediate postnatal period that can even cause a damage to the metabolism of the lens. Hypoparathyroidism, which is a very common association, and Loeys syndrome. You know that it's a kidney affection as well as the eye. Alport syndrome and myotonic dystrophy. See, these are some of the metabolic and genetic diseases, and very commonly Down syndrome. We find a lot of Downs. I mean, patients coming with trisomy 21 coming with cataract very soon, maybe 3. I mean, by the first or second decade, invariably they will have a lens opacity. And trisomy 13 and Marfans. Marfan not only subluxation, they may also have cataracts. So these are some of the most common metabolic and genetic diseases which you should be actually, trying to find, because it is easy to, or there is a possibility of detecting it by serology or various examinations. And then comes the most, this is the most favorite of all the things. Whenever there's a cataract, we talk about torch infections, torch and other viral infections in the mother cause a maternal. These are the maternal infections which cause the bilateral cataract in a child. And the most common ones, torch, especially rubella, we just talked about, that is something, they're all preventable. Some of them are preventable if you can prevent the infection in the mother, and you can probably do a great deal of help. And these are the common, they're detectable by serology. And anomaly, they are obviously by examination, aniridia. Most of the aniridia children also develop cataract along with glaucoma. The anterior segment dysgenesis. Okay. Dr. Kiran, which are the anterior segment dysgenesis that you can name? Like if I ask you, what are the names of some of the anterior segment dysgenesis entities?
IC syndrome.
No. Anterior segment is there's a problem in the differentiation or the cleavage of these structures in the development of the eye early in intrauterine life. We divide them as central and peripheral. The central one that you know, Peters anomaly, and the peripheral is Rieger's and Axenfeld's anomaly. So they are syndromic situations. So you have Peters, which is the central part of the eye is affected, where the peripheral part, the cleavage of anterior, the angle structures. So you have Axenfeld's, Rieger's, Peters, where you have different, variable amount of lens opacity. Lenticonus is another one, and just apart from the curvature, you may also have a cataract. PHPV, another important association. It's a malformed eye with the persistent fetal vasculature with a cataract. So these are the different ocular anomalies which are very obvious on examination. Okay, and you have radiation. If the child has been irradiated by some radiotherapy or an accidental exposure, you can develop cataract. And the most important cataract in epidemic proportion, in some of the areas of India, especially North India around Delhi, is steroid-induced. Steroid-induced glaucoma and cataract are plenty because of the indiscriminate use of some of the over-the-counter drugs like steroid, which is used for chronic allergy. So the children lose sight because of glaucoma, and they also have an associated cataract. And some of the drugs, teratogenic drugs, also can cause. But what about unilateral cataract? So if the child has cataract in only one eye, you don't have to worry too much. There are not many things in the list, but still to list it up, again, idiopathic. So this is if you don't know anything, just say idiopathic. You will be right most times. So idiopathic is the most common unilateral cataract variety because you can't find any reason. Anomalies, again, you may have a PHPV in only one eye. You may have, some of the anomalies the other eye can escape, can be spared. So if you have ocular anomalies, you may have unilateral cataract. Rubella, of all the torch, rubella has a distinction of being affecting one eye only preferentially. So you may have unilateral rubella cataracts as a rare entity. Traumatic, of course, is obvious that child's trauma either during birth or maybe later, the child can develop traumatic cataract. And complicated cataract for various reasons, other problems in the eye, you may have it. So what is the workup of a pediatric cataract? This is important. The child comes to you. Okay, what do you work up with the OPD? Okay, so if you just go through the whatever causes the cataract, some of them are very obvious, like anomalies and things like that. But there are some workup that is required. Workup for a bilateral cataract. If the child has a bilateral cataract, do a torch profile. That is the easiest to do, very easily available, and invariably that if it comes positive, there is something. So it is not only that you just look at the mother and the child both. If you have IgM antibodies in the child, that indicates that there is an infection in the child. It's a recent infection. If you have an IgG antibodies in the child, there will be placental transmission. That doesn't make sense. You should look for IgM antibodies in the infant, which indicates that the child has been infected transplacentally. VDRL, of course, is not much important now because we don't have so much, but still it is something that you can for completion. You give a milk feed to the child and look for, you do a typical Benedict's test. You have a reducing substance, which is basically indicating galactosemia. Okay, you also have a syndromic evaluation because most of the bilateral cataracts are also having a syndromic evaluation. We listed out so many hereditary conditions, genetic conditions. So do a syndromic evaluation. Genetic testing, it is more important because may not be for the first child. If you have subsequent child, then genetic testing becomes important to understand whether the progeny can also get it. And there are some optional lab tests. So what are the optional lab tests in the bilateral cataract? You can look for serum calcium and phosphate. I told you, hypoparathyroidism can cause. If you look for galactosemia, you can look for galactokinase activity. This is available commercially now, RBC galactokinase activity. If you're suspecting Loewe syndrome, look for amino acids in urine. If you're suspecting homocystinuria, look for ureum nitroprusside test. You're looking for Alport, which is a kidney involvement, look for protein. So you can just check the urine for all these if you're looking for a particular entity. Okay, so this completes the whole battery of tests that you do it. What about unilateral cataract? Dr. Dolly, you are there. So what do you do for a unilateral cataract? What test? Are you there? Okay, the answer is very simple. No workup is required. So usually in a unilateral cataract, we don't do any workup. That's why Dr. Dolly did not answer this. That's probably the reason. Okay, so why? Because most of the reasons I told you, it's idiopathic, it is traumatic, okay, or there is an obvious anterior segment dysgenesis and rarely rubella. Okay, otherwise you don't have to really do any workup for a unilateral cataract. Okay, so this is something that you need to understand. Okay, but at the same time, how do you go and manage this? If I told you a small lens opacity, you try mydriatrics, partial cataracts, you monitor, because many a time the cataracts progress even in a child. In a developmental cataract, there is an increased density. And as the lens fibers grow, the cataract can actually either it can lessen or it can increase. So keep a close follow-up about the density and the size of the cataract. And you need to take a call, okay, how to manage that. That is something very, very important. And I tell you, pediatric cataract is a very difficult situation, not in terms of the actual management, but in terms of the parental aspirations. Because a child comes with two parents who think that the child has an eye problem, there's a possibility of child going blind in future. So all that it takes a heavy toll on the parents. They have, they're agitated, they're sad, they are, resentful, they have that remorse, and obviously the child cannot really meet up the expectations of the parents in future life. So that is the one of the most psychological trauma they come with. That also leads to sometimes over expectations from our treatment. They have unrealistic expectations, and sometimes in a young child, in a toddler or in an infant, probably they may still agree because there's not much to expect from the child. When the child starts going to school, so the child may not meet the needs of the school, because our schools are not really equipped to handle children with subnormal vision. The whole concept of low vision aids, or the children which are optimized to take care of children with subnormal vision, we don't have that system. So it's a very competitive world out there in the schools. So a child with a subnormal vision, which can probably manage a scholastic performance if properly guided, really takes a backseat. So that gives a lot of parental stress. So this is where we need to not just be surgeons, we need to be counselors ourselves. We need to do a lot of counseling to the parents. We also have to coordinate with the teachers, sometimes physiotherapies, and so many pediatricians. So it's a whole gamut of this activity, which is a very, very, quite a stressful situation and a very challenging for the pediatric ophthalmologist. So once you do a surgery, it's only the first step. But once appropriate optical correction, because the eye is growing, there's a changing refractive milieu, and amblyopia sets in. So you need to monitor, and it's a lifelong process. At least in the first 8 to 10 years, you need to really take the child along. So if you are putting an IOL, okay, then the whole thing, it's a very complicated thing out there. So which lens to put, when to implant, okay. So one simple, for the takeaway for the postgraduates is, don't try to implant a lens in an eye which is having a corneal diameter less than 9 millimeters. Bigger the better, but at least it should be 9 millimeters. With the presently available lenses, which are not customized for a particular eye, the commercially available lenses, single piece lenses, okay, don't try to push them into an eye which is having a corneal diameter less than 9 millimeters. You will be creating a lot of real estate problems within the eye. Okay, and which formula to use? You have a lot of formula for adults, but for a child, is there a separate formula that you need to use? And what power? I think this is the most bugbear of the entire discussion. Like, how much under correction, what power to use? It's a big question mark. Everybody has their own ideas. So there are a lot of, sometimes we do a disservice to a child by not really following the science or the current guidelines. So I think this is a platform wherein we have a lot of pediatric ophthalmologists, and we can really come out with some consider end of the thing. So which formula to use? I think basically in an adult, if you're operating an adult cataract, these formula becomes extremely important. We are trying to take away all the the inaccuracies of the formula by coming out new formula every day, because whatever adult eye is already grown. So whatever eyeball you're going to put inside is going to decide the vision post-operatively. And that is a patient which has got a high expectations. and that decides the surgeon's outcome of the surgery. So any refractive surprise is definitely a big no-no for an adult. But in a pediatric cataract, you are trying to put in a lens with a very provisional mindset. You don't know really what you're doing because the child's eye grows. The cornea keratometry is flattened, the axial length increases, and finally you don't know what power you end up with. What is the refractive outcome as an adolescent or when he reaches adulthood? We have no idea. So with this highest amount of what I should say the inaccuracy in the entire future, or a very unpredictable future, so we have to start off trying to look what is the best the way by which we can go ahead by choosing the formula. See, normally these eyes are very, very small. Like most of the pediatric cataract age group, we operate within 1 year, obviously, most of them. So they have an axial length of less than 20 millimeters. Okay, even though they may grow later, and most of the pediatric cataract patients actually develop high myopia in some cases, but during the time of surgery, they are usually small eyes of normally less than 20 millimeters. That is our usual experience. So SRKT or a holiday 2 formula would actually suit most of the eyes, small eyes. We have a lot of data coming in from various studies, okay, including infant phakia treatment study also, which probably says normally most of the in an adult different formulae will show you different numbers, so you are really confused. But in a child, I think if you probably take a formula, Barrett's Universal 2 applies to everything, including children, and you will be surprised. A lot of children actually cooperate for optical biometry. So we normally think that children are not cooperative. See, we want to put under GA, try to look for keratometry, handheld keratometers and immersion biometers, immersion axial lens. But if you try, probably even you can try an optical biometry even in a child, of some age group or in a cooperative child. So it's always you should try to get the best biometry that is possible, so that you can really decide either you can use an SRKT or a holiday 2 formula. So this is the kind of the best case scenario. But however, changing the formula or whatever formula you're comfortable may not really change the final outcome, because there is a still lot picture abhi bhi baki hai. Anything can go wrong and anything can go haywire. So basically a formula is not the only thing that is going to decide. So little here and there variation may not make a big difference in the final outcome. But the question here is the most, the important question here that we need to solve this controversy is how much to undercorrect. Because the very fact about undercorrection came in because the eye is still growing. When we operate the eye, it's very small. It has a lot of growth yet to come. So it grows up to 12 to 14 years. So whenever the axial length increases, there's a myopic shift. So if you just implant an IOL, whatever is the emmetropic power in a child or in an infant, in a toddler, by the time it grows to 12, 14 years, it will become extremely myopic. You may end up with -4, -6, -10, -12, we don't know. So we are going to create a myopia in a child. So we don't want myopia, means we need to undercorrect the intraocular lens at the time of the primary surgery, so that the child will not end up with a very high degree of myopia. Okay, so this is the whole concept of undercorrecting in intraocular lens power in a primary surgery. But there is a big problem here. When you undercorrect, you create hyperopia at that point of time. Immediate post-surgery, the child is having hyperopia. Hyperopia is an absolutely useless refractive error. Neither the child can see for distance nor for near, and you have taken away the accommodation of the child so that hyperopic effects, it can correct the hyperopia by accommodation. So the child is absolutely nearly blind with a high degree of hyperopia that you create. So this is a situation, we have a devil at the deep sea. Do you create a hyperopia now so that you have a lesser degree of myopia or an emmetropia later? Or you give a full correction, create emmetropia now and end up with a myopia later? So what is the right way to do it? So this, we will probably, come to that. But I want to confuse you a little more before I come to the conclusion. So there are a lot of study, like you had, we have a JCRS, study where they say less than 2 years, 20% under correction, 2 to 8 years, 10% under correction, and infant is 30% under correction. So this is something that can be told in the exam. The postgrads are very happy. So they said 1 year, 30%, less than 1 to 2 years is 20%, and 2 to 8 years is 10%. This is not so easy. This is not so simple. Okay. And also they said some very funny thing, a rule of 7. You have the age plus under correction should become 7. Okay. If you have an age of 1 year, you should undercorrect by 6 diopters. If you have an age of 5 years, undercorrect by 2 diopters. So this is an oversimplification of a very complicated issue. At the same time, you have a lot of charts like this, like looking at the year, you just try to do an undercorrection of a particular number. So like if you see that by 14 years, you put a plano and this keeps on going down from infancy to 14 years. I still, say that these charts do not really have any role now. Okay. My own teacher, Dr. Sudarshan Kokar from RK Center, AIMS, came out with study in, very recently. It is a made in India study, our own study. They had a huge, sample size, and they completely came up with something which really, were agreeing with the results of another very important multicentric study, globally known, what is called as the IATS study, or Infant Aphakia Treatment Study. Okay, Dr. Kokar et al. From India, they said that undercorrection is a farce. You do only 20% undercorrection, very, very young, like 3 to 6 months, because quickly the child grows up and makes it up. By 1 year, it's only 10%. For example, if you have IOL power of 35 diopters at 1 year, you subtract 3.5 or 4 diopters and put 31 or 32. If you are only 5% for 2 years, if you have a child at 2 years requiring a 30 diopter lens, so 5% of that is 1.5 diopters. So you put 28.5. And 5 years and more, it's only 2%. So it's almost negligible amount of undercorrection. So they came up with this drastic reduction in the amount of undercorrections for a very good reason. So I would like to allude to this study. Why I'm very personally attached to the studies. I did my a bit of my study in Charleston, that is Medical University of South Carolina, at Stoma Institute. One of the Stoma Institute in South Carolina, one of the major centers for this study. Dr. Edward Wilson, my mentor, had recruited the highest number of cases for this study. And I've been a direct testimony to in what accuracy, in what dedication and devotion this study was conducted, and how they followed up these children. So this study basically was designed to study a monocular cataract management. I think Dr. Nikhil, Dr. Jai, and Dr. Prasad will agree with me. The most difficult thing is a monocular cataract management, because the normal eye, the other eye, is going to wreck the development of vision in the eye in which we are trying to solve the problem. Because there's a binocular rivalry, the normal eye would not allow this to happen at all. So monocular cataract has been always the most difficult part of the whole problem. So that's why, so how do you manage this? So either you do a contact lens or you do a intraocular lens. So if you have a monocular cataract, either you have to put an intraocular lens or you need to apply a contact lens. So they basically studied the two groups, in which one they put a contact lens, other they put a lens, intraocular lens, in a child. So this gave us an insight into what power and what will happen if you put an intraocular lens in a very young child, and what was the undercorrection profile that they used. So it's a multi-center randomized clinical trial, and they just tried these two, and they had anywhere from 28 days to 210 days. That was the age that they followed up. 114 were randomized. I still remember, I think Charleston had around highest, something like around 26 children were there from that particular center where I was training. So 57 and 57, it is divided equally to contact lens and intraocular lens. So what is very interesting is what happened to them. If you put a lens in a very young child, in an infant, or a monocular cataract, what happens? It's very, interesting that at the end of, they had an excellent follow. Some of the children have been followed up for almost 10 years. So the visual acuity was almost comparable, okay, between the two. But the adverse events are extremely high in terms of IOL growth. You had to really, had a lot of trouble in a child where you put a lens in a very early age, and a lot of surgeries, additional surgeries, 63 versus 12% in contact lens and intraocular lens group. And the complication rates were very high, even though the glaucoma risk was almost same. So this just says that you can put an intraocular lens, but you'll be ready to face complications, multiple surgeries, and if you don't take care, you may have a drop. This particular thing is misleading because the kind of follow-up they had was excellent. So they did multiple surgeries, they followed the child up, the parental compliance was also extremely good. So that is why they had a comparable visual acuity. Probably elsewhere where the resources are not so great, the follow-up is not so accurate, you may not have, the surgery group may have probably more complications or lesser vision outcome compared to the contact lens group. Okay, so what are the key takeaway message recommendations? So if the when to operate a child is 4 to 8 weeks, I told you in the beginning itself, even if it is identified on the first day. Okay, so this is for the first 7 months, do not put an IOL, right? Only contact lens only. And they told the secondary IOL, this is a very interesting fact. We in India do secondary IOLs much earlier because the children, there is no question of contact lens in our children because the parents can't afford, they can't manage, the child won't cooperate, and it is very difficult to get the contact lenses optimized for an infant or a toddler. So in India, this is the problem. We don't have the contact lens which is easily available and it is easy for the parents to follow. So we try to push the secondary IOLs much earlier. But in the West, the secondary IOL is a much delayed option because of an excellent contact lens compliance by the parents. So it is always best to optimize your secondary IOL timing around 5 years, which probably is the right thing to do because by the time most of the eye growth has happened, there's quite a stabilization. You're not going to upset the post-operative refractive error much. Okay, so this is the whole idea. So what are the takeaways? 4 to 8 weeks and no IOL contact lens less than 7. And the best time is 5 years. And you do a secondary IOL early only in cases where there's a contact lens non-compliance, which is the case in India. So we sometimes push to 1, 2, 3 years, depending upon the eye growth and the size. Sometimes we cannot put an IOL because eye is too small, or sometimes the axial length is too small, and the IOL power is enormously very high. So we sometimes wait till those things change, and we try to do a secondary IOL because the child cannot manage an aphakic glasses nor the contact lenses. So this is how it is seen. I just wanted to ask Dr. Rishikeshi, but what about your idea with monocular cataracts? How do you do it in Pune?
I think that as you have already mentioned and stressed, is that most difficult, most of the times frustrating scenario for any pediatric surgeon, because you do the best surgery that you can, but if you are unable to put an implant, an IOL in that eye, then it's already a doomed eye. The more of problem usually nowadays, what all of us are facing is if there is a monocular cataract and it is a PFV, there will be some amount of microcornea, which may not be there in the better eye, may be there in the better eye as well. But most usually we are seeing PFV eyes having a little, at least a moderate microcornea compared to the better eye. So it becomes very difficult to implant an IOL, especially at 6 weeks or 8 weeks of age. And if you can't do it at that time, then you have already doomed that eye. You as in, I mean, it's very difficult scenario. You can't put an IOL at that age and invite glaucoma. But then the contact lens scenario is not that good out here. And that also you've already mentioned. So I think all of us ought to strengthen our contact lens department because that will be the best and win-win situation without putting an IOL at that age in the one eye. What we can target is at least a 30%, 40% vision compared to the better eye. That itself, I am hearing the trend, or we are reading about it in the West. People have stopped operating on monocular cataracts. So I think that just tells us about the story that does.
Dr. Walimbe, what about your contact lens experience?
Yeah, it's a good question. Actually, the unicolor cataract is a different ball game altogether. Quite frustrating. But again, my take is if the child is diagnosed a little late, means it's a developmental cataract. So after around 9 months of age, only I put an IOL, even though the IATS recommends 7 months. But if I have a good follow-up, if the parents are quite educated, then only I put the IOL at around say 9 months. Otherwise, my cutoff still at 1 year of age, even in uniocular cataract, provided I have a good follow-up. Fortunately, I have got good cornea colleagues which help me in contact lens, giving of the contact lens to these patients. And of all the uniocular cataracts I've done up till now, the best visual acuity, and according to me, was I think 618 or something. But that was the best what I could get. But most of the times the vision hovers around 660, 636.
618
In the
was
best of them.
amazing. 618 was amazing, I would say.
Yeah,
Amazing.
that was the only thing. But all in all, overall, it's basically a frustrating situation. You
Is
have to
there-
have
Yeah. No, no,
a
bolo.
good follow-up, especially the postoperative glaucoma. It's quite messed up, I mean, by many of us. So the checking of eye pressure is very, very important. Checking of the squint, BSV, everything, of course, but the checking of the eye pressure is a must, especially post-operatively in unilateral as well as bilateral cataract surgery.
Right.
That's my take.
Dr. Kelkar, with that?
Yes, sir.
Yeah. So we are all sharing our miseries of monocular cataract management.
Actually, you have covered everything so well. And Valimbe sir also has said all the things that mainly that bother us. But yes, secondary glaucoma should be looked at. And I think fundus examination of the child at least 6 monthly is very important.
Yeah.
Because sometimes if IOP measurement is not possible, then fundus examination can give us an idea. Look at the optic disc, look at the periphery, because if they are you have done an anterior vitrectomy. So
Yeah.
it is always better that we keep checking. There is always a myopic shift happening in that eye. And it is always nice that you send them to the retina colleagues, and however uncooperative the child may be, they should undergo proper indirect examination. And if the need be, maybe under anesthesia.
I think I can't agree more. I think there has to be a ritual of examination and anesthesia every 6 months for even a cataract. I think a lot of things you cannot do it on the OPD with the child crying around. So I think corneal diameter. See, even that. I mean, I'm a glaucoma specialist too. I think that increasing corneal diameter itself can be an harbinger of this undetected glaucoma. Intraocular pressure and disc evaluation is all something that we normally miss. I think this is one area I definitely agree with you all that we miss glaucoma in the post-operative period. It may come several times, several years later also. One of the reasons that has been quoted is it is the eye with the cataract is not just a normal eye with just a cataract, not like an adult. When there is a cataract, there is something wrong with the entire eye sometimes, including the outflow channels. The outflow channels, the angle structures also may share some amount of abnormal development. You only look at the cataract. You can't look at the angle. You can't see anything there. So what is obvious morphologically is cataract that you manage, and you sometimes leave the glaucoma, either it's undetected or it comes out later and we fail to detect it. I think that is something. So the procedure that is done is the lens aspiration or cataract aspiration or phaco aspiration with a primary posterior capsular axis. So this is where the difference from an adult cataract with an anterior vitrectomy with or without a foldable eyeball implantation, depending upon the age group that we have discussed. So this is the procedure that we do. I'll just quickly go through. So it's like you have a zonal cataract here. You can also do a scleral opening. There are many institutions and doctors who actually prefer a scleral entry rather than a clear corneal entry because the closure at the end of the surgery is not very good. There can be leaks immediate post-op. So but the suturing of these all corneal incisions, including the side ports, is mandatory in a child because the biomechanics of the cornea in a child, in an infant, is different. So you need to actually take care of this. So this is something very, very important. So you stay in the capsule in cases where you can probably the tearability improves. So it's more for that rather than for the visualization. So what is very important is the rhexis. I think the difference here is the rhexis runs away very quickly. It's a very highly elastic capsule, and it always, the rhexis size becomes bigger than what you intend to. If you plan for 4, it becomes 6. If you plan for 6, it will go away. So you have to really grasp and grasp. I think if you use a good premium viscoelastic, like, Helon, GV, or so, it normally tends to, it's not like in an adult, you can just, catch at one place and try to manipulate the whole thing. But here you need to grasp and twist multiple times, because it invariably becomes bigger. And if it goes away, then again, the problem of IOL implantation can get more complicated. But once you do that, it is not much of a problem. But be wary of certain posterior subcapsular cataracts where there's a defective posterior capsule. There's a dehiscence or a congenital absence of posterior capsule. If you look at it carefully in a slit lamp or in an anterior segment OCT, you can actually see some whitish particles in the anterior vitreous behind that portion, which we call as a fishtail sign, which indicates that there is actually an absence of posterior capsule in the center. Of course, removal of lens matter is a no-brainer. Anybody can do it, very easy, because there is hardly any, it just comes off. It's a more very, very easy to remove. And this is the primary posterior capsular rhexis. So you make a nick, create a flap. And for the people, beginners, it may be surprising to know that the primary posterior capsular rhexis is as easy or as difficult as anterior rhexis. Maybe sometimes easier. So you just have to probably, it's a very thin one. It's almost 4 to 5 microns thickness. So you need to hold it and try to, make a circular opening. So this opening should be obviously anywhere between 3 to 4 millimeters only, because you are implanting the lens over this in the bag. So if you make a too small one, obviously you will not be leaving much of the visual axis clear. So the visual axis 3 to 4, and once you do that, you need to remove the scaffold of the anterior vitreous, because if you leave the scaffold there, again the PCO can happen over it. So take away the scaffold and implant the lens. You have 2 rhexis here. Open up the bag with a good viscoelastic, put Helon or viscoat between the 2 layers, create a space, and a single piece lens, hydrophobic lens, and try to get that space between the 2 rhexis, and it opens up slowly. The memory sometimes of these lenses are very beneficial, because you can slowly, take your time to put the haptics in the right place. And if you have a 3-piece lens, you can even do a capture. And always suture the openings, and that's it. So this is something you can even sometimes even intracameral steroid also. So the rationale is visual axis opacification is a common complication. It causes amblyopia and difficult to do a YAG laser in case of young children. So it defeats the whole purpose. So you need to make around 3 to 3.5 millimeters. And if the child is even an older child, if it is mentally challenged or not cooperative or having a nystagmus, you better rather do it in such children, or having a plaque in the center, you better do it. So you can also do this with forceps. You can actually do, I just show you a small video, like I already put the lens. So I can just go underneath it, and between the capsule and the thing, I can go and do it. If you are not very sure of putting the lens, if you're having some kind of a technical difficulty, you can actually do it even after putting the intraocular lens also, which is much safer, because already the lens is in place. At the same time, probably the much easier one is to go with a vitrector. So you don't have to really bother. Take the vitrectomy, probe towards the PC, catch it with the irrigation on. You can actually do a nice vitrectomy, not only eat away the central 3 millimeters of the posterior capsule. You don't have the nice round edges, but you can also do the anterior vitrectomy in the same situation, so that you create a primary posterior capsular opening. We don't call it as rhexis. At the same time, you also do an anterior vitrectomy. So if you have a plaque like this, then probably you are left with no choice, even in an older child, to do a primary posterior capsular rhexis and put a 3-piece lens into a capture. So anterior vitrectomy is very important to remove the scaffold, and in the bag implantation is the best choice. But there are some situations where you have lost the anterior rhexis. So this is a situation where the anterior rhexis is lost. And so here we need to do a primary posterior capsular rhexis. and put a 3-piece lens in the bag. So once you have put in the bag, then you can capture the optic in the. So now what you're doing is we have a 4 millimeter posterior capsular axis. I'm capturing the optic in the primary posterior capsular axis so that there's a nice fixation of the entire lens in the bag. It doesn't move, it doesn't rotate, and it also kind of prevents the PCO. So this you can make out the ovalization of the PCC by the capture. So I think steroids are very important. Do not taper steroids too quickly because the child can develop inflammation. At least 6 to 8 weeks have to be tapered. And homoatropine drops in the beginning to basically to prevent synechia. And a very close follow-up is important because these children have excessive inflammation. So we need to avoid a posterior synechia or iris bombay or such complications because it's very difficult to put drops. The parents may miss putting drops so that it may not go into the eye. So make sure that this does not happen. And as we already talked about glaucoma, which is a very high incidence and usually undetected, we need to keep a watch. Retinal detachment actually on an older child because they develop high myopia. All these children of pediatric cataract develop high myopia. And the biggest bugbear is the amblyopia. That is the most important thing because we create anisometropia because of undercorrection. That child, if not properly corrected with glasses, will develop form vision deprivation amblyopia. If it is a monocular cataract, then it will definitely prevent, because of the rivalry, it will develop a much profound amblyopia. So basically, the most important refractive management and anti-suppression exercise, especially in an asymmetrical cataract or a monocular cataract, is important. If both eyes have the same amount of cataract, same density, then there is no need of patching because there is no rivalry. If there's an asymmetrical cataract, then you need to do a patching. That is something very important. So it's a hydrophobic lens. You can put a single piece, that is the most preferred in the bag. If it is a 3-piece, you better capture it in the posterior capsular axis. And a monofocals are preferred because if you put a trifocal or a multifocal, it's a totally a different ball game because the eye is growing. You don't know the end result, what is going to happen. At the same time, toric lenses, most of the toricity in the children changes. We have with the rule astigmatism, it changes to against the rule in old age. So there is always a transition. So do not fully correct toricity. If it's a high toricity, always undercorrect the toricity if at all you are planning one in a much older child, because that is something very, very important. And also there is a posterior corneal astigmatism, which again changes with time. So toric lenses are not much preferred unless there's a very high amount of astigmatism, and it is preferable to undercorrect the toricity. Multifocal and trifocal lenses, even though in some older children has been, especially monocular cataract, has been found to be useful, still it is a very, very controversial area and it is left to a lot of variation. So we don't normally prefer to put a multifocal or a trifocal. But again, I told you, the biggest problem is the anti-suppression exercises that decides the final outcome, not the technique of the surgeon. How compliant are the parents, how cooperative is the child, and how committed is the ophthalmologist will decide the outcome finally. I think the amblyopia therapy is the single most important factor, which is the reason for suboptimal visual recovery. Again, bilateral versus unilateral. Bilateral amblyopias, like obviously after visual recovery, they do improve, but unilateral or a profound amblyopias are difficult to manage. It's because of the anisometropia or the ametropia that we create. And if you have a young child with aphakic spectacles, if you're not doing a contact lens, you give aphakic spectacles. Very small kids like infants and toddlers, they don't really wear it. There's a decentration. When they're lying down, the vision is no axis is not properly aligned. So there's a lot of problems with aphakic spectacles, which again promotes amblyopia. And very importantly, in any asymmetrical case or a unilateral case, occlusion and active vision therapy is the mainstay of treatment. Because there are so many other techniques, but still occlusion remains the final mainstay. And to end my talk, the takeaway messages, which all my panelists will agree, is early surgery. This is where we need to preempt, we need to prime the pediatricians and the neonatologists. And in a surgical technique, no half measures. Just because somebody is doing an adult cataract doesn't mean that he can go away with, a pediatric cataract. You need to manage the capsules well. You need to put the right type of lens. Okay, it is not that a young patient, there's a patient who cannot afford, we can't put a hydrophilic lens, okay, in a child. It has to be no half measures. At the same time, what is more important is the post-operative refractive correction amblyopia therapy. The surgery is just the beginning of the problems. The next is what take to come, and a very close follow-up for complications and the way it turns out. And in select cases, you need to probably do a genetic counseling. So again, my heart goes to MOS, especially the president, Dr. Taswala, for giving another opportunity to meet all my friends on this platform and to share my little knowledge about pediatric cataract. Thanks once again to all the people out at MOS for having me in this webinar. Thank you once again.
Absolutely fantastic. It was a big learning for us also. Forget the postgraduates and this. Everybody had a lot of learning with this. And very nicely put up. You have covered up almost a book, Dr. Krishna Prasad. Fantastic. I enjoyed it thoroughly. Nikhil, over to you for the question answer session. Let's have about 10 minutes or so of question answers if they are there on the Facebook or this. Sayyed, can you just post the question answers here on the chat box of Dr. Nikhil?
Yeah. Okay, so Dr. KP, Dr. Varimbe, I think Dr. Zais had to leave in a hurry for some thing. But how about the Marfan syndrome children with the subluxated lenses with cataracts? What is the trend that you guys follow at MM Joshi or Dr. Varimbe? Question number one. Question number two is, do you prefer doing a peripheral iridectomy in most of the cataracts or you don't? If yes, why? If no, why? And there was another one which I forgot, which I remember down the course. So let's start with the first one. Marfan subluxated lens with cataract, what is your preferred? Both of you.
Okay, I'll take it up first. There's always a struggle in our departments between retina and the pediatric ophthalmology departments.
Yes.
The retina people lay hands on them, they will do a lensectomy and do a scleral fixation. And our department of retina is extremely adept in doing, because they were the earliest to start. They have done all types of scleral fixation, you name it, and they have a huge series. So it happens. But at the same time, as far as science is concerned, there are always pros and cons for everything. We actually tend to preserve the capsule. We do all acrobatics, Ahmad segments, Sionis and fixing the capsules and things like that. We try to preserve the thing because it actually is much easier in a Marfan's rather than in an adult child with a PXN. It's a generalized zonulopathy. Okay, you have more problems trying to fix the bag because it can still continue to worsen. But normally in a Marfan's, it is much easier because the removal of the lens material is not difficult. So that is not a problem. Wherever the lens is, you can always get away with a small rexis, take away the contents and pull the bag to one side. You can use iris hooks or capsule hooks to pull it to one side, fix the Ahmad segment and still put a lens. But having said that, I think the final answer is not out because we really do not have an answer which method, completely taking away the lens and putting a scleral fixation. It all depends. I think I have only one submission. It is basically the way in which the primary surgery has been done. If you've done an excellent scleral fixation without disturbing the vitreous base, without causing a damage to the posterior segment, I think they do well because there are a lot of complications in a bad scleral fixation surgery.
Correct.
Same applies to the preserving the capsule also. It's basically about the experience of the surgeon, what he's doing it. I think both are equivocal. I would go with that. And about the PI, peripheral iridectomy or whatever surgical iridectomy, I don't think it is necessary as a primary procedure. If at all there's a severe plastic iritis, there synechiae and all that, then there is a reason to do it as a secondary procedure. As a primary thing, I don't think I have found a need to do it as a primary procedure in an uncomplicated case.
Okay.
Yeah, you covered it all. But my first, coming to the question of Marfan's, first of all, I will try to even preserve the lens. If it is a very small subluxation, I would try to give basically a good correction. If there is not much of an astigmatism, if there is not much of an amblyopia, I would mainly try to preserve the not to cataract the lens If it's especially if it's a clear lens, I won't do the surgery. I'll just give the glasses and associated amblyopia treatment. But if it's a cataractous lens, if the subluxation is more, I agree. I would try to preserve the capsule. I'll try to use the CTR or CONE, and as far as possible, try to put a hydrophobic acrylic lens. And if by any reason I'm not able to, preserve the capsule as well as, and then my personal choice is removal of the lens with the vitrectomy with a scleral fixated IOL, obviously with a good follow-up. That's my take on Marfan's. And as far as PI is concerned, till 10 years back, I used to do PI in all patients, maybe because of the more reactions I used to get because of the subnorm. I would say the machines were not good that time. But nowadays, I would do PI only if I suspect, if I expect some uveial reaction, more iritis, then only I do the PI. Or if I'm not able to do the rexis, in spite of doing so many pediatric cataract surgery, I'm still not 100% sure I would be able to do the perfect anterior rexis. So if the rexis, anterior rexis goes away, if there is no, good centration, then I would definitely go for a PI. So that's the answer for your second question.
And what about the iris flaw? Everybody's talking about. Hi, sir. You want to stop it?
No. You want to continue? I was just going to ask you also. You have asked the panelists. You are also one of the panelists. So I would like your take also on the same thing. And in addition, what about complicated cataracts and associated with glaucoma? How do you manage? You are a high volume surgeon in HUSI at the head.
Yeah.
What is your take?
So we get, I think complicated cataracts are, if you're posting 4 pediatric cataracts, 2 of them will be complicated at HUSI, because being a referral center, all sort of cataracts come to us, which is always a challenge and very gratifying as well. Quite a few of them are post-traumatic nowadays, as Dr. KP already mentioned. You see a lot of post-trauma, post-corneal tear people coming with pediatric cataracts, which are very bad. So yes, again, the third thing is you let the reaction subside, wait for at least 3 weeks, 4 weeks. Don't be in a rush, because you're not really aiming at saving the child from amblyopia in an eye that has been torn into 2 and sutured back. We are basically going to try and do a good surgery, put the IOL, if possible, in the bag, if not in the next possible best scenario, without causing too much of reaction or without causing too much of chronic iritis. And of course, trying to prevent a secondary glaucoma. As far as possible, you still have to try and get how much ever anterior CCC as possible. If not 100% anterior CCC, at least whatever, 50%, 60%, and then fashion the IOL such that if the tear is in whatever one direction, you place the haptics in the perpendicular direction. If not, you put the 3-piece hydrophobic in the sulcus, and single piece lenses are not to be put in the sulcus. That I think is a very important thing. And in such cases, in these cases, a good, because many a times the PC will be primarily opacified. You see a primary PCO in most of these complicated cataracts. So you need to do, irrespective of the age, 12 years, 10 years, if there is a corneal tear or if there is a juvenile rheumatoid arthritis with uveitis related cataracts, it's better to open up the PC, do a good vitrectomy, provided your retina colleagues have allowed it. In some cases, in post RDIs, post silicone oil filled eyes, they would say, don't open up the PC, we'll see what to do later. So these things, in conjunction with our glaucoma, cornea, and retina colleagues, we have to find out what's the best way forwards. In these cases, I would 100% do a good PI, because there could be pupillary block, there could be so many other things, reactions. Place the IOL as well as possible, preferably in the bag, even if there isn't 100% CCC. Try and fashion it such that IOL stays there if it is single piece. If not, the 3-piece in the sulcus. I think that is the way.
What about complicated cataracts, the post-op protocol? Do you use systemic steroids also in cases where there is a lot of inflammation?
Yes,
or you manage it? I would like to have all the panelists to answer this, because it's a very important question. Crops up in all majority of the pediatric cases with uveitic component is very heavy. How do you manage that? Do you use cycloplegics also on a regular basis?
Yes.
And what type of cycloplegic do you prefer? Each of you can answer it, please.
Okay. So 100% if there is the risk of iritis, or if there is complicated cataract or post-GRA cataract, we would start steroids at least 8 to 10 days before surgery in a low dose, in association with our rheumatology colleagues. They sometimes just 5 mg of steroid, of course, according to the weight. 5 mg of steroid over a period of 8 to 10 days just quietens the eye, makes it good enough, like a good playground for us to play the entire story in, and to be followed up for at least 15 to 20 days post-operatively. Having said that, quite a few of these would be steroid responders as well. So you have to keep a very close eye on. If I prefer prednisone acetate eye drops, I don't prefer giving antibiotic steroids together. I give moxifloxacin separately and I give prednisone separately. And you have to look out for NCT on NCT, whatever we are getting. And we have to gauge, depending on the corneal clarity or edema, whether there is any steroid response. So prednisolone acetate does throw up quite a huge steroid response in quite a few kids, but I think it is a very good way to keep the inflammation down. I really don't prefer to give antibiotic steroid together because I don't want to taper the antibiotic and bring up resistance to that antibiotic molecule in the child. So I think that is the better way to do it. Loteprednol doesn't play much role in the complicated cataracts. It has to be a strong steroid.
Atropine and cycloplegics?
100%. So if the child is less than 3 years, 4 years, and trauma is too much, or complicated cataract is too much, we would put the child on atropine eye ointment BD at least for 5 days, 4 days, 5 days, and to be followed up. We stop the atropine and we start homatropine. I don't give cyclopentolate at home because we are not sure about the punctal occlusion, that whether the parent is going to do it or not. Homatropine is safer than cyclopentolate with almost equal effect. Atropine is obviously the best cycloplegic, but again, you have to give ointment and not eye drop at home. Because again, the punctal occlusion may not be done by every parent or may not be understood by every parent. So atropine ointment, taking care not to touch the tip of the nozzle and putting only a rice grain size atropine ointment morning and evening for 3 to 4 days. I think that suffices. Followed up by homatropine for 8-10 days and then tapered alternate night and stop.
What about steroid responders? How much of anti-glaucoma agents do you use and what is the preferred one?
So our glaucoma team is again very excellent and very aggressive because it's the need of the hour for that time. Dorzolamide is the preferred anti-glaucoma agent in these children, most safe, doesn't throw up a reaction, and it can be stopped very smoothly. So preferably a plain dorzolamide if it is just a very mild reaction, and Dorzox T, or dorzolamide with timolol if it is slightly more. Generally that suffices, and you stop the child, stop the prednisone acetate, because it's generally, for me, it is the prednisone acetate that the kids are on and they throw up a steroid response. As soon as you stop that and start Dorzox T, in these cases we would shift to loteprednol. So that generally works.
Very good. Dr. Krishna Prasad, anything different in the management of the complicated cataract with uveitis, with uveitic membrane, pupillary membrane coming up in children?
I'll only add one point. I was rather talking about the intraoperative part. Apart from all the post-operative he said, I prefer that, like, the time that you start anything, your post-operative drops out of the GA recovery and all that, by that time already the pupil is bound with the plastic choroiditis, already the membrane forming. It will take several days to think. It may create an iris bombay and all that. So what I suggest is intraoperatively, before you conclude the case, 0.1 ml of the dexamethasone. I normally give an intracameral steroid. Also, I give a subconjunctival atropine. So that the pupil is already slightly dilated by the time even you start your medications. So instead of creating a problem and then trying to solve it, intraoperatively you create a drug delivery in such a way that you already have it effect going on by the time the child recovers and ready for the drops.
That's a good idea.
Everything what Nikhil said would be the right thing to do.
Prasad, anything different?
Yeah, I agree with Krishna Prasad. In fact, all my cases, I don't give intracameral, but I always give dexamethasone plus atropine subconjunctivally at the conclusion of surgery for all my patients. As far as steroid drops are concerned, prednisolone drops usually to be continued till 8 weeks, unlike in 4 weeks for adults. And the cycloplegics, I prefer homatropine. In fact, cyclopentolate itself can induce more iritis in kids. So my preferred choice is homatropine. I usually give it for 4 weeks.
Okay.
I usually give it for 4 weeks. So that's the and atropine only in selected patients. And your another question was oral steroids. Oral steroids only in indicated patients in which they are systemically indicated. But all my routine patients or with patients with uveitis, I personally prefer not to give systemic steroids. I can increase the dose of topical steroids. And obviously, as Nikhil correctly pointed out, we have to monitor the intraocular pressure.
Perfect. So nicely answered, all three of you. Nikhil, more
Sir,
about your this thing, moderation. Any more questions
yeah,
you'd like to ask?
I had one important point to bring up, and for both again, Dr. Walimbe, Dr. KP. With the younger children, 2-month-old, 3-month-old, and 4-month-old, are there any? I don't know. Yours an eye hospital, isn't it, Dr. Krishna sir?
Yes.
So, do you have a special NICU arrangement, one bed with a ventilator, deep fib, and all of that as a backup? Or, I mean, sometimes we are not really sure whether that 1.5, 2-month-old children we can operate at just pure eye hospitals, if you know what I'm saying. So we take help from some corporate or general hospital, NICUs. So that was a slight concern that we are facing sometimes. So what is your take on that?
Yeah, how do you manage that? Yes.
Very
maybe.
small kids and sick kids, we
Correct.
have a pediatric anesthesiologist.
Ah,
So we wait for him actually because he's working in another medical college. We try to look for his free time.
neonatal anesthesiologist sort of.
Pediatric
Right.
anesthesiologist. So he's done a fellowship in pediatric anesthesiology.
Ah,
So his view of things are totally different. Like it's not like any other usual anesthetist. So, and we also have the thing ready. Like we normally operate and shift the patient to a neonatal ICU or a pediatric ICU. We don't keep the patient post-operatively with us. That is already a part of the whole plan. There is nothing like it is sent as a contingency. It is sent as an elective manner.
correct.
Bed is ready, the child goes there and we visit for the first day till the child recovers and comes out of the whole thing. Because it is very important till the child recovers and completely becomes fine. Okay, we have had a lot of problems in the past, so we have been made this. So any child, at least, first 1 year, okay, we normally don't, especially we operate very small kids like 1 month, 2 months, 3 months, or
Correct.
6 weeks. I think this has been a practice. We immediately shifted to the, we have a hospital close by. So next to our hospital, we shifted there.
That's a good idea.
That way I am quite lucky because I operate all my kids in one of the super specialty hospital called Dinanath Hospital, in which we do have very good pediatric backup, pediatric NICUs. We have got pediatric anesthesiologists. In fact, I have got a series of patients, especially the rubella, in which till few years back, our cardiac OT and ophthalm OT were similar in just the next to each other. So I have a series of patients in which the patient was done for the cataract and the same patient was wheeled into the cardiac for his heart problem. So in the same GA, we used to do both. So for me, it's a luxury as well as because I can operate and all the patients are by default kept in NICUs.
That's a really good. That's a blessing, sir. That's really a blessing.
I agree.
So we had a very, very nice session. Each one of you have contributed so nice. In fact, lots of things to learn today. Now, not only for the postgraduates and the fellows, but also the consultants, seniors, juniors, at all strata. I think everybody has taken, there is a go-home message which has been given by all three of you. Fantastic moderation by Dr. Nikhil, as usual. That is why I had wanted him. So, and as a panelist also, beautiful explanation given to each and every question. A big thank you for sparing so much time. I think we have spent almost 1.5 hours. I was planning about an hour, but the discussion was so good. I wanted more. I think more and more, there are a lot of queries coming in also in my mind, but now it's past 10:30. So we'll have it at another session on pediatric later on. So great going by all of you. Thanks a lot, each one of you, for contributing in a big way, and the enrolled people who are always there for a backup. Before we conclude, we'll have a 1-minute video, a gallery view shot with all the videos on. The postgraduates also joined in. It was an interesting session, and my backbone, Dr. Ajay Joshi, as always, is there for the official Thanksgiving. So over to you, Syed, the quick video on of Entored before we call it a day and have the Thanksgiving.
Thank you.
Syed, yeah. Yes, can we all have the video on? So we have a quick gallery view shot. Sayed, you please take it. As for the posterity, everybody put your video on. And then Rajesh to conclude the Thanksgiving. Thanks each one of you. Yeah.
Big thanks
All
to
the
you, sir, for
postgraduates are
arranging
still
this.
smiling. So they have learned a lot today.
No, Dr. Taswal, a wonderful initiative from you because,
Yeah.
yeah, brilliant. I mean, these discussions are so valuable. So thank you, in fact. Thank you so much.
In fact, we are planning to have the booklets in case we have a sponsor also to distribute to all the ophthalmologists all over Maharashtra. So I am looking there because this is a very good session. We don't learn in the books. Very nice tips have been given by each one of you. I enjoyed it thoroughly. I don't know about the postgraduates. They must have for sure. And very nicely put up. Step by step, he was explaining it. And you people were putting very valuable inputs, each one of you. So it was a great session. It's just
Dr.
not
KP really
flattery,
made it
but
easy.
in reality, we enjoyed it.
Yeah, that's nice.
So a big thank you once more, all of you. Rajesh, over to you.
Yes, sir.
Syed, are you with the? Are you taken the gallery view shot because we
Yes,
want
sir.
it on
Yes,
the
I've
MOS
taken it, sir.
website? Yeah.
Yeah,
So,
discussion
thanks
can
a
go.
lot, sir. Thank you,
No,
Nikhil.
no, 2 minutes, just a minute, because Rajesh is the most important part of our this thing. A
Yes,
pleasant
yes.
Thanksgiving by him.
So
Without
you-
that, nobody should go.
At least you have to bear me for 1 or 2 minutes.
Yes.
Discussion,
Yeah, Rajesh.
With pleasure.
discussion
With
can
pleasure.
go on and on as far as cataract is concerned. Had this webinar would be on retina or neuroophthalm, the session would have ended by 10 p.m. as Dr. Taswala has planned for. It was really wonderful discussion on pediatric cataract. Thank you, Krishna Prasad sir, for highlighting on nitty-gritties of pediatric cataract surgery and sparing your valuable time as well. Thank you, Dr. Nikhil, for conducting it so well. Dr. Prasad sir, Dr. Prasad Vayende sir, Dr. Jai madam for agreeing to panelist. Special thanks to residents for joining and staying till the end. Of course, they had no choice but to stay with us.
जबरदस्ती पकड़ के रखा नहीं they were enjoyed it. You can see the faces.
Yeah, they must have enjoyed
They
us.
have learned a lot. Good.
I'm also thankful to all those who are joined on virtual platform, and of course, thanks to Entoad also for their technical support.
Definitely.
Yeah,